So welcome to week 5. We're going to review 2 chapters. The PowerPoint presentations, one of them is really, really long. So I'm not going to go over every slide. We'll do the 2 PowerPoints. We'll do a brief Kahoot. You'll take a break and you'll come back and you'll take your quiz. So I'm going to go ahead and start with the first chapter, which is chapter 23, sensory or neurological. And then once it's open, I'll go ahead and start sharing my screen. Okay, so sorry about that. So this is the first chapter, chapter 23, sensory and neurological conditions. So there's obviously several different things that go into sensory and neurological. So we're going to start with the ears. Most common ear infection is otitis media. So what do you guys think otitis externa is? It's not an otitis media. What would be the difference between an otitis media and an otitis externa?
External, that would be outside, like in the canal outside.
Yeah,
Isn't it?
exactly. Yeah. So the otitis media is behind the tympanic membrane. So when you look in the ear, you see that tympanic membrane. So it's behind that. And the otitis externa is swimmer's ear, or it's the ear canal. So it's still painful, but it doesn't necessarily require the oral antibiotics. They usually treat it with drops that just go in the ear canal. So you do need to know the difference between an otitis externa and an otitis media. And then the otitis media, it's inflammation of the middle ear. So it's the part of the ear that's on the other side of the tympanic membrane. And we all have eustachian tubes that protect the middle ear, and they provide drainage, and it helps equalize air pressure. So what do you think is different about kids versus adults in terms of the eustachian tube? Have you ever heard of them putting tubes in kids' ears or treating ear infections with tubes? So the eustachian tubes in kids tend to be flatter. So they're not at the same angle. So they don't have the same ability to drain fluid from the middle ear. So they put tubes in those eustachian tubes, and that helps keep those tubes patent, and it helps kids that have problems with recurrent ear infections. So this is just showing you what the tympanic membrane looks like. You can see here it's kind of bulging and red. So normally it's like a pearly gray color, like a blue gray. So this is something that you would see when you look in the middle ear with the otoscope, if there's an ear infection, and otitis media, middle ear infection. So what do you think kids behave like if they have an ear infection, an otitis media? Are they crabby?
Yes.
What else?
Completely miserable, pulling on their
Completely.
ears, crying.
Okay. And they can have a fever. So it's common in kids. And what do you think some teaching points are? Like, as a nurse, if your pediatric patient has an otitis media, what do you need to teach the parents about otitis media?
Avoid going into the pool.
Okay, so avoid getting, water and stuff like that, or, in your ear. Okay. Once they're diagnosed, do they normally take antibiotics?
For that, yes.
Yeah. And what happens, like, if the antibiotics are for 7 days and the kid feels great after 5 days, should the parents stop?
No, you continue.
Continue, you give the full course. So what do you think some complications are if you don't treat ear infections?
One is loss of hearing
Uh-huh.
and
Yeah, that's
damage on the nerve. I forget the name of the nerve in the ear.
it's going to be the acoustic nerve, which is cranial nerve 8. So very good. Yeah. So if you have a kid that has hearing problems and they weren't born with hearing problems, one of the things you have to think of is if they've had recurrent ear infections. So we talked about this. you know, it's usually broad spectrum antibiotics. You need to make sure they take the full course. Sometimes they do the eardrops. The eardrops are most common with the otitis externa. And then the surgical intervention, that would be putting the tubes in the ears. So that is done for kids that have recurrent ear infections that have required multiple antibiotic courses. So it sounds like a couple of you have had, or are parents and your kids have had ear infections. So Walter said that, sometimes kids, they can develop hearing impairments because of recurrent ear infections, and kids can have hearing impairment for other reasons. So it's just important when you're working with kids that have hearing impairments, that you're at their level, that you make sure they can see their lips, your lips, that you're speaking slowly and clearly, and kind of using, very concise, clear communication with them, but you should give them the best opportunity to understand what you're saying. So this is kind of a picture of, the appropriate approach to speaking to a child that has hearing impairment. And then we're going to move on to the eyes. So who has heard of strabismus? Has anyone heard of strabismus?
Isn't that cross-eye?
Yeah, and this is a picture of it. So strabismus, yeah, so the eyes aren't focusing on the same object. And a lot of times kids squint when they have strabismus, and they might tilt their head to one side or complain of being dizzy or having a headache. And then who has heard, there isn't a slide for this, but it's in your book, who has heard of amblyopia? I can put it in the chat. Has anyone had a kid that, or a parent that had a kid that had amblyopia? These are the two kind of common eye problems that you might see in kids. So amblyopia is when one eye doesn't have the same visual acuity as the other. So a lot of times it won't focus. They'll just use their strong eye as much as possible. So what do you think the treatment is for amblyopia and strabismus?
Corrective glasses.
So the amblyopia, they will use, because that one does involve vision, they usually start with putting a patch. Yeah, and where do they put the patch?
Over the good eye.
Over the good
Isn't
eye.
the
So they, yeah.
Strong eye,
Right. So they put the
or the weak
patch
eye?
over
I
the
think
eye
isn't the
that.
strong
Go ahead, Walter.
Isn't in the strong eye the one that sees better? Don't they put
Yeah,
the patch on that eye?
they put the patch on that eye to force the brain to use the other eye. So kids are pretty miserable because they have two eyes and one of them doesn't work, and then you put a patch on the good eye and force them to use the bad eye. So yes. So this is another slide on strabismus. They can end up having surgery. They usually start with the patch, and then they can also do eye exercises and glasses that have prisms in them that help bring the cross eye into alignment. So kids can also have eye strain, they can have vision problems, and sometimes if kids aren't doing well in school, or if they have a short attention span, you need to be making sure that you're thinking about vision and hearing and getting them screened. And sometimes if you correct that, then they'll do better in school. And then retinoblastoma is the condition of the eye where there's actually a tumor. So you can see this kid here. This is the eye that has the retinoblastoma. So it's like a cat eye. It's like a yellowish white reflex. And they can have problems with vision. They can have strabismus. They can have, pain, etc. in that eye. It's usually treated with chemotherapy and radiation. In very severe cases, they'll actually have to remove the eye. And this is one of those things that a lot of times parents will notice at first. So if the parents ever tell you that the kid kind of has this weird yellow tinge to the eye, you should definitely follow up and look at it. So who has heard of fixed dilated pupils, or have you ever in your hospital experience seen a patient that had fixed dilated pupils? What do you think it means if you have fixed dilated pupils?
Fixed dilated pupils.
Something with your
So,
brain.
huh?
They don't
Something
react
with
to
your
light.
brain.
Something with their brain. Very, very good. So, right. So when you have fixed dilated pupils, that means your optic nerve isn't responding normally. So if you have increased intracranial pressure, like acute brain hemorrhage or something like that, you might see these fixed dilated pupils. So it's never normal to have fixed dilated pupils, and this is considered a medical emergency. And you should be thinking of increased intracranial pressure and putting pressure on the optic nerve. So, fixed dilated is a medical emergency, but there's lots of things that can happen that affect our level of consciousness before you get to the point of a hemorrhage or fixed dilated pupils. So all of these things here on this slide can change a patient's level of consciousness. So this is looking at like your oxygen level in your blood. So if it goes below 60 or if your carbon dioxide goes above 45. So this is kind of looking at like that blood gas that you get on patients a lot of times when they come into the emergency room. So a fall in your oxygen or a rise in your carbon dioxide. If you have a really low blood pressure and you're not getting normal cerebral blood flow, and then things like drugs. Increased ICP is kind of the most severe. And then just to always remember that when you have a fever, that increases your oxygen needs. So sometimes when kids have a fever, they have increased oxygen demand, maybe they're not getting the oxygen that they need, and then they can end up with an increased or an altered level of consciousness. So what do you think, like, what are some nursing interventions if you have a patient that has an altered level of consciousness, and what sorts of things are you monitoring for?
You want to keep monitoring to make sure they don't get loss of consciousness.
Yeah, so you're looking for any subtle changes, things like if they're having a seizure and you're just monitoring them closely, making sure that everything is still symmetrical. You're not like seeing weakness develop on one side of the body, or they're getting more somnolent, more sleepy. Very good. This is, all of the cranial nerves, 1 through 12. You don't need to memorize all of them. I would remember that number 2 is the optic nerve. Number 8 is the acoustic nerve. So these are the two, when we're thinking about problems with vision or hearing, that you would think about the most, 2 and 8. And this next slide here is just in a logarithm for you to remember all 12 of them. I know for a fact that, you don't need to remember all 12 of them, but I would pay attention to the, the 2 and the 8 for optic and auditory. And being able to remember, if they're having a hearing problem, that could be a problem with cranial nerve 8. So has anyone heard of Reye's syndrome?
Syndrome.
It's
We don't-
liver.
Yeah. Go
I
ahead.
don't know what it is, but I know children can get it from taking aspirin.
Very, very good. So this is like an encephalitis and liver. So think of brain and liver with Reye's syndrome. And it is associated with taking aspirin. So this is why we recommend that parents give either Tylenol or ibuprofen when children have a fever, that they don't get aspirin. So, and it's also associated with viral illnesses, and particularly the influenzas. So yeah, so salicylates is the general term for aspirins. So you do need to remember not just aspirin, but salicylate, which is on the slide right here. So an aspirin is in the salicylate family of medications. So if kids have flu-like symptoms or viral fever, muscle aches, URI symptoms, etc., they should not take any medications that are in the salicylate family, because that can cause them to develop Reye's syndrome. So another sort of neurological problem that kids can have is meningitis. So meningitis, generally speaking, is it's inflammation of the meninges, which are the fluid-filled membranes that cover the brain. So meningitis isn't always an infection. You can have a chemical meningitis, which is you get chemicals that cause inflammation. So meningitis in general is just an inflammation, but it's almost always infectious, and it can be viral or bacterial. So, these are some symptoms that you might see in meningitis. Obviously, when it's infectious, fever and chills, a really bad headache, stiff neck, nausea, vomiting. They can have photosensitivity, difficult to awaken or being really sleepy, being confused. And then they can have like severe neck stiffness. And then in infants, they have that fontanelle that hasn't closed. So they have that soft spot. What do you think happens? Is it flat or swollen if they have meningitis?
Swollen.
It's swollen. And you might see it flatten or sunken if they're really dehydrated. So these are two different tests that we talk about when we're assessing for meningitis. So this one here is the Brudzinski. So you see the kid's flat, and then when you lift his neck up, he instinctively draws his knees up. So as you lift the head, the leg bends. That's a positive Brudzinski sign, and that's a sign of meningitis. And this one here for Koenig, you have them laying flat and you put their leg up to 90 degrees and they can't straighten it. So these are both like one of the ways that if you see somebody in an outpatient clinic or in the emergency room and you're worried they might have meningitis before you do your full workup, you can do both of these. If either one of these is positive, this is a sign of meningitis. So if they come in, the child's diagnosed with meningitis, they're going to be in isolation for at least 24 hours. You're going to do frequent neurological checks. And then you're going to do, accurate vital signs. And you want to make sure that you have a really quiet environment with decreased stimuli, because they can really have a lot of photosensitivity, and loud noises and blinking lights and stuff like that can make them feel worse. So if you have meningitis, you are at increased risk for seizures, but kids can have seizures outside of having meningitis. Sometimes kids have a seizure disorder, and sometimes it can be a one-off, like a febrile seizure when they're young, or they have meningitis and they have seizures, etc. So there are certain things that kind of make it more likely that a child will have a seizure. So flashing lights, when they're really young, startling movements, overhydration, which can lead to like sodium imbalances, or when they have photosensitivity, which is just they're sensitive to lights. So, in terms of seizures, I don't think it's super different than when talking about kids versus adults. You need to know your seizure precautions, like making sure the wheels are locked to the bed, that saddle rail's up, that it's padded, etc. You generally speaking need to know that children's seizure will be kind of targeted, their medication will be targeted to the type of seizure. And that sometimes there are alternative things, like kids can be on a ketogenic diet for some kids that are really not responsive to medications. And sometimes they can also have a vagal nerve stimulator, which is planted internally, and that can help control their seizures. So there's a couple things that they can do if seizures are not
Jasenia, you're so important.
I guess we lost connection.
I thought it was just me. I was like, oh my God.
So I apologize. Was not expecting my internet to go out, so I'm glad you guys are still here. I am so sorry that that happened. So let me pull the PowerPoint back up. I'm glad you guys are still here. I thank you for your patience. Okay. Let me make sure we got the screen sharing that we need. Okay, so we were on the seizures. Let's see here. Seizures. So, remembering that they're part of a multidisciplinary team, that they usually have a caseworker, really close work with their neurologist is important. And whenever we're talking about neurological, we always need to remember things about safety. We went over this, side rails up, etc. So that is the end of the seizures. Has anyone here heard of cerebral palsy, or have you guys ever known a kid that had cerebral palsy? How would you describe cerebral palsy? Or CP? No one's ever seen a kid with CP?
I couldn't hear your question about connection.
Oh, you got it. Okay. Does
Yeah.
anyone?
One of my
Go ahead.
You're talking about a CP patient?
Yeah.
Yeah, like the motor, like the joint, like they don't move properly, they don't have stability, they're like bed confined most of the time.
Okay, very good. So they tend to be spastic, right? They're a contractor. They usually have a hard time walking. Maybe they're wheelchair bound, or they have to use crutches. It's almost always caused by anoxic brain injury at birth. So something in the delivery happens and they don't get enough oxygen to their brain. And then as a result of that, they end up with CP. So they have contractures, they need braces to help straighten their hands out. They can also have mental retardation, but it doesn't always. Sometimes you can just have the musculoskeletal problems of CP without the mental retardation, or you can have both. So if you work in pediatrics, you will undoubtedly see kids that have CP. So,
And I see them with trachs also.
You see that with what?
And they usually have a trach.
Yeah, it's not unusual that they'll have a trach. Yep. They don't always, but they certainly can. So sometimes they need more respiratory support. Absolutely. So you always want to make their life as normal as possible. So they have communication boards. Sometimes they can't speak, but they can look at things with their eyes. So they can have a communication board where they can look at things with their eyes, and then they can communicate somewhat with their communication board. Even if they have mental retardation, they still need stimulation, and they should still be in school, and they should learn as much as possible. They should have all the adaptive devices, et cetera, that they need. So try to really make their life as complete and as normal as possible. So whether they have CP or they have some other reason to be intellectually impaired, they have a lot of the same needs as other kids. So, encourage them to do art therapy and play, try to give them all of the same sort of resources and help them communicate as you would any other kid. So one of the things that you need to do is recognize that they're different. But that they still want to interact with other kids and play, etc. So try to set them up where they have tasks that they're able to do and that they're able to do well, and make sure that parents have realistic expectations about what they're going to be able to do. So always make sure that you're doing an individualized plan of care, and that when you're in the hospital, you maintain the home routines as much as possible, help them do their self-help activities. If they're don't use a diaper at home and they're in the hospital and they're able to walk, you don't want to just put them in a diaper. You want to make sure that they're really maintaining as much of their independence as possible. So always, you know, emphasize the child's strengths and not focus on their weaknesses. Don't use, you know, stereotypes or generalized terms. Make sure you're involved with the school nurse. There's also like lots of support groups, et cetera. All these things are things that you should be really focusing on, the kids that have either physical or intellectual disabilities. And sometimes, you know, like when we think of Down syndrome, there's like a very specific facial appearance and you have Down syndrome, but you can have kids that have mental retardation or intellectual disabilities that have a normal face. So don't assume that you can tell by looking at somebody if they have any sort of intellectual problem. So, you know, obviously kids nowadays are playing a lot of sports. So you need to be worried about them having head injuries when they're playing sports. And you do need to remember that if they have a concussion that causes amnesia, that's more serious than a concussion alone. So always be thinking about whether or not they're really confused or they have amnesia after they had like a head injury where they have a concussion. This slide goes over, you know, basic signs and symptoms of concussion. One of the main things you need to remember is you don't always see the problems with a head injury right away. They can happen after a couple days. So you need to make sure that parents know the signs and symptoms and they're monitoring their child appropriately. So shaken baby syndrome. Is this something that you guys have heard about? What do you think shaken baby syndrome is?
Oh,
Literally when
that's
someone shakes the baby and their brain hits the skull.
Right. So this is like, it's a form of child abuse, right? Parents get frustrated and they shake the baby. So you would, you know, have some permanent brain damage. It can cause permanent brain injury or death. And you're going to, you know, generally speaking, have symptoms of increased intracranial pressure or head injury. So they might have vomiting, really sleepy. Sometimes you can see a little bit of blood in their eye. So you always need to make sure, what do you think, like you teach parents, what should a parent do if their kid is screaming and they don't have any help and they feel like they're going to lose it? What do you educate parents to do in that situation?
Walk away.
Walk away. Right. Your kid's safer in the crib with side rails up and you just go in the living room and you're going to ignore the kid for a few minutes. You might have to take them to the hospital, something like that. But if you're ever to the point that you're just so frustrated, it's better to just walk away. And one of the things that we see with brain and spinal cord injury is posturing. So there's two, there's the decorticate, which is more of a spine injury, and then decerebit, which is more of a brain injury. And you can remember them, the decorticate, you know, think of the C, your wrists kind of come in like this as a C, and decerebit, your wrists go out more in the shape of an E. So you do need to remember, you know, the two types of posturing, and you should be able to recognize what area of the nervous system you suspect based on how they're posturing. So this is never a good sign. If your patient comes in posturing, that's always a sign of really severe damage. One of the things we talk about in terms of neurological damage is increased intracranial pressure. So who has heard of Cushing's triad? What is Cushing's triad? What three things do you see in Cushing's? There's a little thing here. Yeah. Huh? So you see increased blood pressure, decreased heart rate, and irregular respirations. So these things together are ominous. This is a sign that there is too much pressure inside the brain, that their ICP is too high. So these are the vital sign changes. You know, one in isolation is not that concerning, but if you see the drop in the heart rate and an increase in the blood pressure and they're breathing really erratically, that's a very ominous sign that they're having problems with increased intracranial pressure. So you should recognize that. Other things that you can see is this vomiting, papilledema. This is some blood that you can see when you're looking in the eye, severe headaches, changes in their level of consciousness. But in terms of the vital sign monitoring, this is your Cushing's triad over here. So we talked a little bit when you're doing neurochecks, you need to really be paying attention to subtle cues. If there's any subtle changes in how they're behaving, that can be a sign of an impending neurological problem, and you need to be documenting everything very closely in their medical record. And these are some of the things that you're going to be paying attention to, how awake they are, their level of consciousness, their cranial nerve response, if there's any changes in their ability to stick out their tongue or move their cheeks, etc. If they're posturing, their pupils, if they have a bulging fontanelle, these are all specific things that you can be paying attention to when you're doing neurological assessments. So something that can happen is near drowning. So obviously educating parents about the dangers of swimming pools and being around water. And just to remember that it's the fourth leading cause of death in children. So it is something that happens, and you need to make sure parents are educated about it. So if they are submerged for more than 10 minutes and they don't regain consciousness within 24 hours, that's a very ominous sign that they will eventually die from their submersion into water. So that is the end of the sensory neuro. Does anyone have any questions about that PowerPoint?
No.
No. Okay. We're going to go on to musculoskeletal, and this one is 70 slides. So we're not going to be able to go over every single slide, but I will highlight, the important things. So we're actually going to, I would say you guys have this as a reference. We're going to start on slide number 5. So a lot of times in pediatrics, we go over what is different about kids versus adults, because most of you are probably more familiar with adults. So who do you think fractures more easily, adults or children? And a kid
Fractures.
falls, yeah, who's more likely to develop a fracture, an adult or a child?
An adult.
An adult. So kids' bones are a little bit more pliable, they're softer, they're not as brittle. So that's one of the main things. Something that you need to always think about, this upper corner here, this white square, it has the diaphysis is the long part here, and the epiphysis is the top part of the bone. This is a long bone like your femur or your tibia. So there's what's called a growth plate here. So a fracture is more complicated for kids if they have a fracture of their growth plate or where the epiphysis is. So if the fracture is up here in the top part of their bone, that can affect the ability of that bone to grow over time. So you worry about those fractures more. So this is just kind of, going over that the musculoskeletal system, they really work together. They develop about the same time in just the gestational age of children when they're developing in utero. There's lots of things that you can learn about kids based on just observing them. So they're a lot, are they standing up? When should kids be standing up and walking? At what age?
By 1.
By 1. So we always talk about, some kids are different. So certainly 100%, if they're 18 months and they're not walking, then they need a referral. So it's abnormal not to be doing it by 1, but are they standing up and cruising? They're just not walking. If they're not doing it by 18 months, that is a big red flag, and you need to follow up on that. Sometimes parents worry about their kid's gait. They think that there's something wrong with them because they kind of waddle. So that's normal. They have a wide, unsteady gait, and they kind of toddle back and forth when they're toddlers. So as they get older, the gait gets more narrow and they start to walk more normally. So just to kind of encourage parents to, have patience, their kids will more than likely walk normally as they grow older. It just takes a little bit of time for them to not be so short and squatty. And then, as they exercise more and more, their gait will improve. But, if there's any pain or anything like that, they need to report that. But if the kid is just kind of, clumsy and falling, but still getting up and playing and not reporting any pain, it's probably normal, and they'll outgrow it. So when you're doing, you know, we talked about neurological, you're doing is everything symmetrical on both sides of the body. You do the same thing when you're doing a musculoskeletal assessment. These are just a brief overview of a bunch of different types of studies and scans that they might do for children that have musculoskeletal problems. Has anyone heard of the CBC and the ESR? What do you think those would be used for? CBC you're going to see all the time, right? That's a very common test.
Yeah, that's a complete blood count, and the ESR is a set rate.
Erythmatite sedimentation rate. So this is going to be looking for inflammation. You know, if you have an elevated white count and an elevated ESR or an elevated CRP, that's more likely that you have an infection. So you might see this when they have osteomyelitis or a septic arthritis. So sometimes when they have bone pain, they do additional tests to see if the cause of the pain is an infection. So in this presentation, we talk quite a bit about traction. So I'm going to move on to the traction slide here. And then we'll go back to the soft tissue injuries. So this slide here goes over different types of fractures. And there's a couple that I really want to make sure that you know. So a spiral fracture, this is this one in the right upper corner, and there's the blue arrow. So you think about like grabbing a bone and moving the bone in two opposite directions. That's like not a normal thing that happens to a bone. So this particular type of fracture is associated with child abuse. So like imagine somebody grabbing a kid's arm and then twisting in two opposite directions. That can cause this spiral fracture, so you're more likely to see this in child abuse. And then this compound fracture. What do you think a complication of a compound fracture is?
Infection.
Infections, right? You got like this open skin, so you're likely to get, or you're more likely to get an infection. And this green stick fracture here, what can you tell me about that type of fracture?
It's a bend, not a break.
Yeah, so you can see the bone, there's like an indentation, but it doesn't go all the way through the bone. And how about a simple?
That's like a crack.
Yeah, so this one's not really likely to need surgery, right? Like the bone isn't displaced. It's not, the two ends are still meeting each other. So you should be able to cast this and this bone will regrow. But you're not going to need to put a pin in here because the two ends of the bones are still meeting each other. So, and we talked about this at the beginning that, you know, kids are less likely to fracture than adults. If they have any pain or tenderness or swelling, you should pay attention to it because they can have fractures even though it's less likely. And then what bone in your body do you think is likely to require traction? What type of fracture?
The hip bone.
Commuted.
Yeah, so for sure, like a femur fracture, which is that big bone at the top of your leg, right? So femur fractures, a lot of times they go into traction before they have surgery. And there's two main types of traction. So all of the traction that we talk about today, you can use for femur fractures. So the difference is going to be the age of the child. So Bryant's traction is for under the age of 2. And you can see this little kid here. So this is probably a femur fracture, and they are pulling the legs up to realign the bone. So this is going to be a form of skin, or I'm sorry, a form of, yeah, skin traction, because it's using, like, you know, they're connecting the waist and everything to something that goes on the outside of the skin. Versus pin fractures, they put a pin into the bone. So this is, you know, they're younger children, they don't weigh that much, and instead of putting something in the bone, they wrap the bone with the gauze on the outside, and that's what gets connected to the weights. So the one thing that you need to remember about Bryant's traction is only for children under the age of 2, and then they lie on their back with their legs elevated. And then there's another type of traction that's called Buck's traction, and this is going to be for your older kid. It can still be used for femurs. And in this one, you know, for Buck's traction, their leg is flat with their heel a little bit elevated, and you're pulling the bone in opposite directions to align it. So the weights are going to be hanging off the bed here. So for bucks traction, you need to make sure you remember it's older kids, and they can't be in a bed that's greater than 20 degrees. So they can't be up in high Fowlers, because then they'll slip in the bed and the traction won't work. So it can be used for femur, and it can be used for just putting the head of the femur back into the hip socket. And that can happen in a condition called the slipped capital femoral epiphyses, which is just a condition where the hip socket pulls out. So they can put them in bucks traction to realign the head of the femur into the hip socket. So Bryant's is little kids under 2, bucks is older kids. And then there's a second one for older kids called Russell. And the only difference between bucks and Russell is that in Russell, they elevate the knee. So there's like a sling under the knee that pulls it up off the bed, but it's still that it's moving the bone with the weights on the end. So it moves the bone out to pull it back into alignment. So this is not the best picture. You see bucks though, the leg is on the bed with the weight hanging off. And in Russell, there's a sling around the knee that pulls it up and the weight's still hanging off the end. And this is both for older kids. And then the Bryant is for the younger kids. So what are some things that you think about for traction? What are some things that you're going to monitor as a nurse?
Circulation.
Okay. So you're going to do frequent neurovascular checks, pain, pulse, color, ability to move fingers and toes. Where are the weights? Are they flat on the floor? Where are they?
They're dangling.
They're dangling. They're always free dangling. Okay. And then this is the picture of the skin versus pin. So if they have something that's going into the bone, then obviously you need to be worried about infection. So making sure you're doing good skin care. And this is the picture here, you know, complications. You can have muscle wasting. They might end up with urinary retention, decreased lung expansion because they're not really able to move around in bed. They're increased risk for clots because they're not moving. They can have skin breakdown. So all of those things are pretty logical, but these are all things that you need to be worried about if your patient's in traction. So, you know, things that you need to make sure that you're doing, that their body is in correct alignment, that you're not having their head a bit elevated, because if they're moving, then they're not going to have their leg in the correct position. You need to do range of motion for the uninfected joints. So if it's just one leg in traction, the other leg you should be bending, moving their arms. They're going to have those SCDs, those squeezers on to help prevent blood clots, frequent neurovascular checks, paying attention to skin integrity, pain medication. And if they're old enough, they'll frequently have a trapeze so they can kind of pull it up and reposition themselves. So this is just going into more detail about the importance of the neurovascular checks, you know, the pulse, the color, the cap refill time, whether it's warm or not, their ability to move, the fingers or toes. These are all things that you're paying attention to, that you need to be documenting as the nurse. So, you know, sometimes they don't need traction, and for a fracture, they can just have a cast on. And even though that is generally speaking a less complicated fracture, you still need to be worried about compartment syndrome, which is, you know, loss of tissue perfusion in the area that's casted. So then you would be paying attention. You're still going to be doing neurovascular checks in a cast, just like you would be if they're in traction. Okay, so we're going to go back now and talk about soft tissue injuries. So who knows the acronym that we talk about if they have a sprain or a strain? What do you recommend that they do? It's not a fracture, it's a milder injury.
Rice.
RICE. And what does RICE stand for?
Wrist, ice,
Compression and elevation.
Okay. Very good. So you got this kid here, rest, ice, compression, elevation. So you do need to know that. And then there's we talk about soft tissue injuries. So this is going to be, you know, injury to the tissue that surrounds the bone with it, but without a fracture. So contusion is just, you know, blood capillaries that have broken. So you'll see some bruising there. And a sprain is twisting of ligaments, and a strain is twisting of tendons. So who can tell me the difference between a ligament and a tendon?
A ligament is bone to bone and a tendon
Okay.
is muscle to bone.
So you need to know that. So like an application style question would be like, you would suspect that a child had twisting of the tendons if you were told they had and you would have to remember that tendons was associated with a strain. So you're going to need to be able to differentiate between a sprain and a strain. And you need to know that the ligaments is bone to bone and the tendon is muscle to bone. You need to be able to differentiate between those two. So the treatment is going to be the same, right? It's going to be the rest, ice, compression, elevation, but you do need to be able to differentiate between a sprain and a strain. So now we're going to go over some infectious problems that you can see in the musculoskeletal system, and we're going to start with osteomyelitis. So osteomyelitis is an infection of the bone. It usually occurs in really young kids under a year or between the ages of 5 or 14. And we talked about like that compound fracture. You're at risk for osteomyelitis if you've had that fracture and the breaking of the skin. It can also not be preceded by an injury, but it's you know, an infection in the bone. And there's, you know, the most common organisms are going to be your Staphylococcus aureus and then your Haemophilus influenza. And these kids that have osteomyelitis, they usually have quite a bit of pain. Sometimes they just present with like limping and they don't really know why. There can be warmth around the site. Usually the most common thing is it's fever and pain. So this is, you know, we talked previously, this is one, you know, if you have an elevated white cell count and an elevated SED rate, you're going to be leaning more towards an osteomyelitis. You're going to be having those inflammatory markers that are elevated. You don't always see it on an x-ray, so it's not uncommon that if you're worried that they'll get a bone scan. And one of the most important things that you need to know about this is the treatment lasts for weeks. They almost always need a PICC line. So not only do they need antibiotics for an extended period of time, they need IV antibiotics. So they're going to get a PICC line and they're going to go home and get antibiotics for like 6 to 8 weeks. So there are other musculoskeletal problems that kids are actually born with. The most common is going to be Duchenne's muscular dystrophy. So Duchenne's is a congenital genetic, why didn't it do that? Congenital genetic problem where they're not necessarily born right away, or they're born, they can look normal, but then they're not walking or they're clumsy, and then you ultimately diagnose them with muscular dystrophy. And then let me see here. So it's usually diagnosed after the age of 2. But then when you think back about it, they have problems during infancy that you didn't necessarily pick up on. And the main thing is that they're clumsy and they really don't have the same ability to walk. And this is a common sign. This is called growlers. So this is a kid that's fallen and is having a hard time getting up. And this is a kid that has muscular dystrophy. He kind of gets himself in this position as he's trying to stand up from the floor. So it's progressive, you know, it gets worse over time. And there's usually some element of intellectual impairment. So what do you think people with Duchenne's generally die from? What, like if you have progressive muscle weakness, what would that lead to?
They develop the respiratory problems. A lot of
Yeah, very good, Walter.
pneumonia and all that stuff.
Yes, very, very good. So they they almost always die of cardiorespiratory problems. So they can have a cardiomyopathy, and then frequently they're trached and on a ventilator also. But later in life, they almost always die of cardiomyopathy. There is another form of muscular dystrophy called Becker's, which is also congenital, etc. But it tends to not be as severe. Duchenne's is more common. So now we're going to talk about a couple of different problems that kids can have that we don't always know why they happen. They're not congenital, they're not caused by an injury, they're not a fracture. So the first one is the slipped femoral capital epiphyses. So this is displacement of the femur head. And it's not necessarily related to trauma. They usually limp, and they have an inability to bear weight. And we talked about this, you can use Buck's traction for this to pull the femur head back in. So this is one of the uses of traction that's not a fracture. And then leg cap perthes is a change or a disruption in the blood flow to the femur head. So it can cause more long-term problems because there can be necrosis of the femur head because it's not getting normal blood flow. But having said that, it usually goes away without any treatment. But it can lead to long-term problems because it can cause necrosis of the femur head. And it's also going to be, they're going to limp. They might have limited range of motion. Like I said, it usually heals spontaneously, but they might have problems over time. So in rare cases, if they have this leg cap perthes, they might end up with necrosis of the femur head, and they might end up needing a hip replacement surgery, like later in life. So we're going to talk about a couple of different cancers. So osteosarcoma is the most common bone cancer in children. And kids that have had a retinoblastoma or have had radiation therapy for other cancer are a higher rate of developing osteosarcoma. And it's a cancer that unfortunately metastasizes pretty quickly. And if it does, it usually goes to the lungs. So you would expect them to have pain and swelling in that bone. The diagnosis is confirmed by a biopsy. And for this one, the osteosarcoma, they do a resection or an amputation. So they tend to cut out, if it's in the tibia, they would do a below the knee amputation. They take out the section of the bone that has the cancer. Versus Ewing sarcoma, which is not as common. This one is primarily treated with chemo and radiation therapy, but they don't necessarily do the amputation. And it also may metastasize, and if it goes to the lungs, which is the most common place, it's a bad prognosis. So, I would recognize that there are two types of bone cancers that you see in kids, and then the one that you normally do the amputation or the resection is the sarcoma. And then for both of them, they metastasize, and the most common place that you would first see the metastasis is the lungs. So we think of arthritis as being an older adult problem, but you can have what's called juvenile idiopathic arthritis, which is actually an autoimmune disorder. So it tends to have exacerbations and remissions. And it is usually treated with, common autoimmune medications like steroids. And it's broken down based on, if it's systemic, if it's polyauricular, or if it's parauricular. So these two words, poly is more than 5, and joints, so multiple joints being involved, and parauricular is less than 5. So it's kind of, determined, its subcategories are determined if you see like all body responses like the rash or problems with your eyes, that's going to be systemic, and then also based on the number of joints that are involved. So usually you see it in associated with very high fevers, like up above 103 that lasts for several days. It's not uncommon that they have a rash. They might also present with abdominal pain. And this is another diagnosis where you might see these elevated inflammatory markers. So this is the ESR that we talked about with the osteomyelitis, and also C-reactive protein is another inflammatory marker. So these can be elevated in these kids, both of them. And this is what I was telling you, that the polyauricular is more than 5 joints. And this is kind of showing, you know, hands and feet, swollen, tender, and you see it more often in girls. And then if it's parauricular, then it's less joints involved. And in the parauricular, you're more likely to see problems with the eye, where they have a pain in the eye or inflammation of the iris. So, you know, with most things, the goal of treatment is to have, you know, as much of a normal life as possible. So reduce the joint pain and swelling, maintain as much mobility as possible, promote independent functioning. It is a chronic illness, you know, there have remissions and exacerbations. So you kind of have to educate parents to know that this is something that they'll continue to deal with throughout their childhood. So this is kind of reiterating that and giving them the support that they need, helping them communicate, maybe getting the school nurse involved or whatever, so that they have the support that they need at school also. So this next one, torticollis, this is the picture. What do you think's his neck, right? He just can't move his neck midline. So congenital just means they're born with it, or acquired, something happens after they're born. It's almost always congenital, and breech or forceps deliveries are the most common cause. But you might see it if they have other problems like congenital hip dysplasia. So do you think these kids need surgery most of the time, or does it get better over time? What do you think?
It all depends how severe it is.
Yeah. So surgery is pretty uncommon. They normally can, you know, do some muscle stretching, etc. And it'll usually resolve by 2 to 6 months. So you teach the parents to do this passive stretching, range of motion. You know, if it's really severe, they might end up needing surgery. But most of the time they can do the range of motion exercises to resolve it. All right, so scoliosis. Does anyone have scoliosis or know someone in their family that has scoliosis?
No, I've seen it many times.
Okay, and so you can see it here. So this is going to be the lateral curvature of the spine. And how do you screen for scoliosis?
Well, you have them bend down and you can see the curvature.
So it's more common in girls. You have them stand up with their feet equal distance, and they lift their shirt up and they bend down and they touch their toes, and you look for the curvature of the spine.
Yeah.
So there's 2 types. So functional would be, you know, you're just because of your posture, you've ended up with this curvature. And then structural, there's something wrong with the shape of the vertebrae. And you can end up with problems with both your hips and your shoulders, depending on the degree of curvature. So depending on the degree of curvature, that's going to determine your treatment. So mild scoliosis is going to be up to 20 degrees, the degrees being the degree of curvature. And then they just do like physical therapy, stretching. 20 to 40 degrees, that's where they wear a brace. And then if it's over 40 degrees, that's when they need a spinal fusion surgery. So you do need to remember how you categorize scoliosis as mild, moderate, severe. So up to 20 mild, 20 to 40 moderate, severe, greater than 40 requiring surgery. And you need to remember, you know, when you need to wear a brace and when you need to have surgery. And the surgery that you get is a spinal fusion surgery. So when we're talking about, you know, kids, we always need to remember that they're probably likely playing sports and they can end up with sports related injuries. And we talked about a lot of the sprains, the strains, the fractures. We've talked about all of those things. You might see this term again, the stingers or burners. This usually refers to damage to the nerves of the fingers, like a baseball player might have a stinger or burner where they've hit the finger multiple times with a baseball, and it's just kind of nerve injury that kind of stings, and it's going to be in your upper extremity. These are some of the sports that you're going to be worried about having a greater risk for injury. So unfortunately, when we're working in pediatrics, we always have to remember that you can have musculoskeletal problems, et cetera, because of domestic violence or family violence. So in terms of child abuse, we generally say that it's not something that is associated with one particular social class or anything like that, but there are certain things that make child abuse more common or might be triggers. So, recent unemployment, somebody losing their job, alcoholism, dysfunctional family, stress for the parent. And then also remember that disabled children are more likely to be abused. Sometimes parents just really can't deal with having a kid that has CP or having a kid that has Down syndrome or really hyperactive, et cetera. So this kind of just goes over certain things that can trigger child abuse in a family. We think a lot about physical abuse, but that's not the only type of abuse. So emotional abuse, kind of destroys their self-esteem. Emotional neglect kind of goes along with the emotional abuse. Sexual abuse, I think we know what that is, and then physical abuse and neglect. So neglect is kind of failure to provide basic needs, and then abuse is actual physical injury. So you need to remember that as a nurse, you're a mandatory reporter in all 50 states. So regardless of where you're working, you are required to report to Child Protective Services if you suspect child abuse. So once a report has been made to Child Protective Services, they're required to investigate. So once the report's been made, the CPS will inform the parents, and they do a home visit within 48 hours if there's something serious that they're really concerned about. If not, it'll be within 72. And just in general, unfortunately, if you're working in a pediatric hospital, you're probably going to eventually take care of a child that has been exposed to child abuse. So trying to help them manage their feelings, teaching them coping skills, making sure they're getting the therapy, focusing on the things about themselves that are positive, are all things that you're going to be doing as a nurse to help them overcome their exposure to abuse. All right, so what are the things that you think you might see? If a kid comes in and it's hot outside and they're wearing a lot of clothes, is that something that you would be suspicious of?
Yes.
Why? Yeah.
Trying to hide.
Yeah, trying to hide something. Sometimes kids that just aren't gaining weight well, maybe they're not getting enough food. So that can be indication of neglect. It could also be something medically wrong with them that hasn't been diagnosed. Dirty clothes, not changing their diaper on a regular basis. In severe cases, you might see some like retinal hemorrhages, especially with like something like shaken baby syndrome. And then, pay attention to patterns, looking for bruises, etc. This slide makes me very, very sad, but I do think it's important. So one of the things that we talk about is bruising or evidence of injury in various staging of healing. So like if you have a kid that falls and hits their leg, they fall forward and they get bruises on their leg, you would expect those bruises to heal at approximately the same time. Whereas if you have one bruise that's kind of yellow and one that's just beginning, that's swollen and kind of tender, that makes you think that maybe there's been more than one injury. So you need to pay attention to the color of the bruise and remember that they change over time. So it starts out just kind of being swollen, then it kind of comes red, purple, and then green, and then yellow, and then brown. And you should remember the general, like 5 to 7 days is green, 7 to 10 is yellow. To, if you're ever presented with information and you talking about bruises that have different colors, then you're going to be worried that those are multiple injuries that have happened at different times, which is a concern for child abuse. So, to remember to always be culturally sensitive in all cases, but when you're documenting abuse, what are some cultural practices that might be misinterpreted as abuse that aren't really abuse that you might have heard of?
I heard the spanking.
So some cultures
Like-
are more likely to spank.
Yeah.
Has anyone heard of cupping?
What was that
Cupping
again?
is
Club?
cupping, cupping. It's like putting, hot cups on the back to try to pull out toxins. You might see like marks on the back for some cultures.
There's
Um,
another, I think it's like coin rolling or something, where
Okay.
they take a coin and they roll it on the back and it kind of leaves well, and it's kind of the same thing as the cupping. That could be
Okay.
mistaken as abuse.
Yeah. So, you always have to be on the lookout. It's weird when you see a bunch of marks on the back. So you need to ask, right? So you need to be aware of the fact that sometimes there are health practices that can leave marks on the skin, and that's not necessarily abuse, but you still need to be aware of it and follow up on it.
I think it's also important to make sure you're documenting birthmarks, because I know there are some
Oh, yeah.
birthmarks that are discolored
Yeah,
that could
very,
look
very
like
good, Reese.
bruises.
Yeah, excellent. Thank you, Reese. So does anyone have any questions about the musculoskeletal stuff? Nope. Okay. I'm going to pull up your Kahoot for this week, and then you guys will take a brief break and you'll come back and you'll take your quiz, and then you'll be free to go.
Recording in progress.
Okay. Okay. Okay, first one. Why are infants more susceptible to otitis media? The eustachian tube is short, straight, and wide. They're always lying down. They have increased susceptibility because of upper respiratory infections, or sucking on a nipple creates middle ear pressure. Yeah, so we talked very briefly that that eustachian tube is just not in the same position. It doesn't have the same ability to drain fluid from the middle ear, and that's one of the main reasons that infants are more susceptible to otitis media. They are always lying down, but it's more that their eustachian tube doesn't drain their fluid. And it is also true that they have an increased susceptibility, but the best answer is that eustachian tube. So a student had a generalized seizure in the school nurse's office. At what point should the nurse call 911? When the child is sleepy and lethargic after the seizure, the child vomited at the onset of the seizure lasts more than 5 minutes, or the child is confused and has slurred speech after the seizure. Okay, so this one was a little bit harder. So it is when the seizure lasts more than 5 minutes. You're really going to be worried about, oxygenation level, if they're having problems with their airway, if it's lasting more than 5 minutes. So has anyone heard of a post-ictal phase after a seizure? So post-ictal is kind of this state of being kind of sleepy and not kind of out of it when your seizure's over. So that's a normal thing. So kind of sleepy, a little bit of slurred speech, maybe confused for a few minutes after the seizure is common, and it usually happens. So that would not necessarily be a reason to call 911, and that's called being post-ictal. And then it's also not uncommon that a child will vomit at the onset of the seizure. So these, sleepy after the seizure, vomiting at the onset, a little confused with slurred speech after, these are all normal findings. But if the seizure is lasting more than 5 minutes, then you're really worried about status epilepticus, a seizure that won't be able to be controlled, or problems with their airway. So what would the nurse include in a teaching plan about the long-term administration of Dilantin, which is a seizure medication? You should give it on an empty stomach. It can cause insomnia. The gum should be massaged regularly to prevent hyperplasia, or the blood pressure should be closely monitored. So this is one you should remember Dilantin for your HESI, for your NCLEX. This is a common medication question to ask students on those HESI, NCLEX sort of standardized tests. So this is, a lot of medications have similar side effects, but one thing that really makes Dilantin different than other medications is it causes gum hyperplasia, or bleeding of the gums and kind of red swollen gums. So you should prepare parents about this, and they can kind of massage the gums, et cetera, to kind of mitigate that side effect. So which assessment finding in a child with meningitis should be reported immediately? So a slight drop in the blood pressure, irregular respirations, tachycardia, or an elevated temperature. Okay. So we talked about Cushing's triad being associated with increased intracranial pressure. Does anyone remember what are the three things in Cushing's triad?
Elevated blood pressure, decreased heart rate, and irregular respiration.
Very good, Reese. So this is why this one is the best answer here is your irregular respirations. This is going to be one of your three things in your Cushing's triad, right? So Cushing's, you're going to actually have an increase in your blood pressure. So a slight drop is not something you have to report immediately. Tachycardia, when you have a fever, when you're upset, you have bradycardia with Cushing's, and an elevated temperature when you have meningitis, you normally have a fever. But this sort of irregular respirations, breathing really fast and then breathing slow, or kind of not breathing consistently, this is going to be the thing that you're most worried about in meningitis, or if you have a kid in general where you're worried about increased intracranial pressure. So the nurse urges the mother of a 6-month-old child to get her child vaccinated with the Hib vaccine. Why? To protect against otitis media, to protect against influenza, to protect against bacterial meningitis, or to protect against skin infections? Good. So Haemophilus B influenza is one of the common pathogens that causes meningitis. So if you have a vaccinated population, you're going to have less meningitis. So it does help protect against meningitis. To be honest with you, it does also protect against otitis media, but like the most important is going to be the meningitis, because this is going to be the more serious infection. So which situation would cause the nurse to suspect a hearing impairment in the child? A 3-month-old with a positive startle reaction, an 18-month-old toddler who is speaking one-syllable words, a 15-month-old toddler who is babbling, or a 24-month-old toddler who communicates by pointing? Yeah, good. So the other ones are going to be kind of normal, right? So you babble, maybe you start with one syllable. The moral reflex is that's a normal reflex in a 3-month-old. But if you have a 24-month-old, you really should, this kid should be using 2-word, me go, 2-word sentences. So it would be unusual for them to be communicating by pointing. What is the best way for the nurse to communicate with a 10-year-old child who has a hearing impairment? Let the child's parents communicate for her. Recognize that the child will communicate at a 6-year-old level. Use gestures and signs as much as possible. Face the child and speak in short sentences. So good, most of you got that. So you don't want to do a lot of exaggerated facial gestures, because that can make it harder. That can make it harder for the child to be able to read your lips or communicate with you. So you do want to face them and speak in short sentences. Very good. Let me quickly respond to student. Okay. So what might the nurse explain as a common treatment for amblyopia? Using corticosteroids to treat inflammation of the optic nerve, patching the affected eye to allow the refractory muscles to rest, using glasses to blur the image of the good eye, or patching the good eye to force the brain to use the affected eye. Yeah, so this is going to be the patch. You would do, you would patch the good eye, which is hard for the kids, so that their brain has to use the bad eye. All right, last one. What information should be given to parents about Reye syndrome? Test children for Reye syndromes if they have a fever, vomiting, and lethargy. Use aspirin instead of Tylenol when the child has a viral illness. Encourage immunizations to prevent Reye syndrome, or avoid salicylates to a child who has viral symptoms. Right. So the salicylates is the category of medication that aspirin is in, and somebody chose to test for Reye syndrome. There's not a specific test. And you never want to give aspirin if they have a viral illness, because that can cause Reye syndrome. All right. Dun, 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 dun. Good job, Reese. Gabby. Marissa. Okay, awesome work, everyone. So I will post the Kahoot when I post the video of the lecture for you to practice. I want you to remember that exam 2 is next week. So Professor Bogart will do her exam review on Wednesday, and I'll do my exam review on Saturday, and then we'll take the exam during class. If you're going to do a proctor on campus, you need to let me know now, or at least 72 hours in advance, so I can get the code out. And there'll be one announcement. Well, I'll put both of the recordings on the same announcement, so you don't have so many announcements, but I will put them, both mine and Dr. Bogart's, out there for you to review. And I attached the PowerPoint for the exam review to the announcement. So if someone doesn't have it, let me know and I can email it to you. I'm going to go ahead and give you a 10-minute break. So come back a little bit after 10:30 and your quiz will be up, and you'll take your quiz and then you'll be free to go. And I'll give you guys a quick second if anyone has any questions to ask me before you go on break.
I
Is
have
there a
quick question.
worksheet? Like for last exam, there was like an actual worksheet for us to work through, or is it just the
Yeah.
PowerPoint?
Right now, it's just the PowerPoint. I might have time to develop a worksheet for you, which then I could send you, but right now it's just the PowerPoint. So yeah, someone asked that they don't have the quiz in the modules. Yeah, the quiz are never, you always have to take them in class, and I turn them on when you come back in. So you'll never see the quiz unless you're in class at the time that we take it. So if you're not in class, then you can't take your quiz. So when you guys come back from your break, your quiz will be there for you to take. Are there any other questions?
I have a couple.
Yeah.
So did you send out the PowerPoint like for the review for the,
It was on the
Exam.
announcement.
and that's for the exam review?
That's for the exam. Yep.
Okay. And then I have a question about the Kahoot, because when
Yeah.
you send them,
Yeah.
I can't, like, I don't know if anyone else has this problem. I can't go through and play it. It just takes me to a thing that has like the answers and the questions. It doesn't really have the option to just play it. I
Okay.
don't know if it's just
Yeah.
set up
So
like that or.
No, I tried to change it so I was assigning it to you and I put the game pin in there. I'll put it in there today, and if it doesn't work for you, please let me know.
Okay.
I was just sharing it, but now I assign it, and I think when it's assigned, you should be able to pull it up. But if it doesn't work, let me know so I can figure it out. Thank you for asking questions, Gabrielle. Does anyone else have any questions? Okay, so it's 10:25. Why don't you come back at 10:40? So take a good break, rest. Remember, the quiz is over last week's information. So it's not what we just went over in this Kahoot. It's what we went over in the Kahoot from last week. If you want to think about what we talked about in terms of child's adaptation to hospitalization. And when you come back at 10:40, your quiz will be ready for you to take. Okay.
Is the quiz up or no?
All right, thanks for coming back. I'm just gonna wait a couple more seconds for people to flip their cameras on, but you can go ahead and log into your Fortis and take a look. Your quiz should be there. If it's not, please let me know.
Can we take the quiz already?
Yeah, if you guys are back, let me see, Walter, your camera's on. If you're back and I can see you, then you can go ahead and take it. That's fine. And then please
I
remember
mean, my
that.
camera is always flickering.
Yeah, I see you. Don't worry about it. I got you, Walter. Yeah, go ahead and take it. If you're here and you're back from break, you can take it.
All right.
You too.
Can you see me?
Gotta scroll through.
It's Gabrielle.
Yeah, and Gabrielle, I wanted to tell you, I put the link. Yes, Gabrielle, I can see you. And I put the link in the pin in the chat. So after your quiz, if you want to make sure it works before you leave, that's fine. Okay.
Thank you.
We can go when we're all done, Professor.
Yes, Reese, you can.
Have a great day. I'm going to bed.
Good night, Walter. Get some sleep.
I'm finished now.
Okay. Thank you, Trinetta. I'll see you next week or
Okay,
maybe in the
thank you.
review. You're
Yes,
welcome. Bye-bye.
Bye-bye.